received double sequential external defibrillation and vector change defibrillation had better survival to hospital discharge. So the new recommendation is to use the double button. Also, immediately after the resuscitation of the spontaneous risk, we have to use the ABCD approach as usual and look after the keeping the saturation between the 94 and 98%. So adrenaline remains standard, but the updated recommendation emphasize context-specific timing, especially in non-shockable rhythms. There are some key differences between the European recommendations, European Resuscitation Council recommendations, and American Heart Association recommendations. Mostly emphasized in advanced airway, so you can see the intubation is preferred to the experienced providers by European recommendations, and for the American Heart Association, mostly recommended to provide the supraglottis approach or intubation. As I said, the waveform capnography, this is mandatory for the ERC and is recommended for AHA. Also, the monitoring of the CPR quality is to keep between the 25 and 30 millimeters, and the capnography for the AHA recommendations is higher than 20 millimeters. Meanwhile, the quality of the CPR has no threshold. Also, for the epinephrine, as I said, it is recommended to do after the 3 shocks. Meanwhile, in the AHA, it is recommended to do after the 2 shocks. The same about the AED and the vector change is not recommended by the European recommendations, but there is no evidence of the usefulness so far as per American Heart Association recommendations. In 2025, guidelines introduced important on the addition of the difference between the 4H, 4Ts for European and in American Heart Association recommendation. It is added the hypoglycemia for 5th H and thrombosis of coronary artery as the 5th T. Also, the slight difference you can see on the slide. The main changes is the usefulness of the vector change defibrillation for adults in cardiac arrest with persistent ventricular fibrillation or pulseless ventricular tachycardia after 3 or more consecutive shocks are not been established. That is a new thing. And one more updated thing, that the hypertension should be avoided in adults after the resuscitation of the spontaneous rhythm by maintaining of minimal main arterial pressure at least for 65 millimeters. The 2025 guidelines introduced importance of the refinements in bradycardia management. Atropine is no longer recommended in cardiac transplant surgery patients or in high-degree AV block with wide QRS due to the potential harm of or lack of the efficiency. Instead, the aminophylline may be used in transplant or spinal cord patients, and glucagon is considered in 2025 ERC updates to the adult tachycardia algorithm emphasize early risk stratification and targeted management. The primary distinction remains between the stable and unstable patients with immediate synchronized card diversion recommended for any signs of the instability. In stable tachycardia, the focus is on the QRS, bites, and rhythm regularity to guide the treatment. There is greater emphasis on caution use of the antiarrhythmic drugs here, avoiding the delays in definitive therapy and continuous reassessment. Overall, the updates reinforce the structured but clinically adaptive approach. Also, the European 2025 recommendations, ERC recommendations, in traumatic cardiac arrest represent a major shift from the standard CPR algorithm toward the cause-directed approach. Priority is given to the rapid identification and treatment of the reversible causes, particularly hypoxia, the tension, pneumothorax, the cardiac tamponade, and hemorrhage. The interventions such as airway control, the chest decompression, the hemorrhage control, and volume resuscitation take precedence over chest compression in certain situations. This situation reflects the key change. Survival depends on correcting the underlying cause rather than relying on the conventional CPR alone. This slide summarizes key differences between 2021 and the previous and 2025, the last one, the recent ERC post-resuscitation care guideline. The most important shift is toward a more comprehensive and individualized approach. In 2025, whole body CT is prioritized in unclear cases rather than default coronary angiography. The temperature management is reframed and strict fever prevention with a lower threshold. There is also the greater precision in hemodynamics targets, delayed catheterization in selected patients, and expanded guidelines guidance for the post-resuscitation arrhythmia and neurological prognosis. The important thing is that the new sections addressed for the rehabilitation, the long-term follow-up, and even unexplained cardiac arrest reflect a broader patient-centered continuum of care. So the 2025 European guideline refine the post-resuscitation care with stronger emphasis on controlled oxygenation, ventilation, and hemodynamics. After the resuscitation of the spontaneous rhythm, airway support should be individualized. Intubation is recommended for the comatose patients, but must be performed by the experienced providers with a capnography confirmation. Oxygen should initially be given at 100% and then titrated to avoid the both hypoxia and hyperoxia. Targeting, as has been said, 94-98% saturation with awareness of pulse oximetry limitations. Ventilation should aim the strict normocapnia using the lung protective strategies. In circulation management, early ECG and invasive monitoring are emphasized, but a defined median arterial pressure target is above 60-65 millimeters, and delayed coronary angiography is selected patients without CT elevation. So, 2025 European guidelines represent the evolution toward the precision resuscitation, aiming not only to save lives, but to improve the quality and recovery. Thank you, and using this opportunity, I encourage you to participate at our oncoming 6th Congress in my country, in Tashkent, Uzbekistan, which is going to be on November 12-13. Thank you. I'm ready for questions if I can.
Thank you, Professor, for an amazing lecture. We'll put the question and answers session to the end of this panel. Right now, we'll have the lecture of great cardiologist and internal medicine specialist, former director of the emergency medicine La Sapienza University of Rome in Italy, Professor Salvador Di Soma.
Good morning, everyone. With you this year, because of a personal issue, to attend one of my favorite meetings during the year, but I hope that I will be able soon to join all of you in another occasion. So today we are going to talk about the importance of recognized mechanism of leading to cardiogenic shock in order to improve our therapeutic management. And there is no doubt, as this recent paper of New England show that cardiogenic shock remain a major unsolved problem. And this is because there are a lot of heterogeneous disorders that can lead to this disease, but also mortality is remaining too much high, around 50% of the patients presenting in acute setting with a cardiogenic shock. So we definitely need to do something better to understanding what is the ongoing situation in order to block it and improve patient survival. In order to make a common definition, there are a lot of data from different important large cohort of patients with shock, cardiac disease, showing that there are two clinical conditions that can be linked with the definition of cardiogenic shock. That is an important tissue hypoperfusion that is also coupled with systolic blood pressure below 90 millimeters of mercury, despite continues for 30 minutes despite the use of vasopressors. At the end of the day, it is also important that we know that cardiogenic shock can be the consequence of many acute cardiac disease, and between these diseases, acute coronary syndrome is always the most important frequent one, like we showed in this multicentric study as a registry of cardiogenic shock worldwide, showing that acute coronary syndrome is the reason of patients develop cardiogenic shock in 70% of subjects. Besides acute coronary syndrome, also acute heart failure can be the reason of a patient developing cardiogenic shock, such as non-myocardial disease, such as critical arrhythmias or pericarditis, and also post-cardiosurgery procedures. So at the end of the day, it's also important to understand which is the etiology of the patient we are facing. Second important step in managing from the beginning this disease is to recognize which stage of disease the patient is in front of us. If it is stage A, that means there is no signs of clearance of cardiogenic shock, such as hypoperfusion, such as reduction of diuresis, but the lactate is always starting to be higher than 2 millimolar per liter. Then the classic cardiogenic shock, where lactate is stable, greater than 2 millimolar per liter, but there is a lot of reduction in cardiac function, such as cardiac index of 2.2 or less, and also in all these patients you want to put a catheter into monitoring hemodynamic pressure and see that the wage pressure is greater than 15 millimeters of mercury. At the end of the day, when you are progressing in the patients in front of you to see that there is an increase in lactate up to 8 millimolar per liter, definitely you want to understand that the situation is very critical. Now, since today we would like to look better into pathophysiological mechanisms, let's summarize from this paper on New England which are the most important phenotypes of this mechanism. First of all, we have just said that it's a reduction in cardiac index that is going to reduce, the flow into the myocardium, the coronary ischemia. But what is important part in this cascade is the initial vasoconstriction that's trying to counteract the reduction in blood pressure is no longer to be able to maintain the pressure and then the perfusion in the organ, because very soon, because of an important inflammatory reaction that will be very soon is crucial in this patient, you have a vasodilatation that leads to cardiogenic shock. So what we can do in order to better understanding this phase? Definitely, there are a lot of biomarkers at different parts of the body that can mirroring the ongoing damage in each organ. Again, inflammatory total body process such as CRP or IL-6, and then you can have, of course, the oxygen saturation, the liver damage such as transaminase, again, lactate that is mirroring with vasoconstriction action, but also gut damage. Of course, troponin, isotroponin, and triple-BNP or BNP for cardiac depression, and also, of course, the kidney function, such as creatinine measuring level. So definitely, you can catch the mechanism of damage, looking at biomarkers as, evidence of each organ damage. We have just said about biomarkers. Blood data is an important one. Blood data, in this paper we showed in European Heart Journal that when blood data is up to the normal limit, is always linked with increased mortality when the patient comes in developing cardiogenic shock from acute coronary syndrome. Just to remark the importance of biomarkers, we have just discussed about the fact that in this cascade from cardiac reduction function to hypoperfusion to ischemia, inflammatory process is a crucial one. And in fact, if you are going to measuring some biomarkers that are referring to this inflammatory process, you can definitely are able to probably to improve the patient's survival, because you are immediately able to understand how the patient is severe. Between these biomarkers of inflammatory damage, DPP3 is an important biomarker. We'll see very soon the importance of this biomarker, because the increase of these biomarkers is linked with depression of the heart function, vasoconstriction, reduction of perfusion, and within kidney biomarkers such as NGAL, you can definitely have a lot of important information to better manage your patients. We have just seen that inflammation that occurs within 48 hours after the initial patient developing cardiogenic shock, C-reactive protein on leukocytes, cancer, good but are a little bit unspecific. Anyway, you can see the inflammatory process that is always important to lead high mortality in these patients because of reduction of ejection fraction and then the severity of shock. So, since we are approaching the concept of trying to have biomarkers that are related to this important inflammatory process in the molecular physiopathological mechanism in the cardiogenic shock, let's talk about the peptidase 3. What is the peptidase 3? It is a biomarker that is located into the cellular level, and it is linked with the good function of angiotensin II system. When there is an hypoperfusion and any damage in the all the cells into the body, these biomarkers translocate from the cell into the bloodstream, and this release in the bloodstream is going to block the angiotensin II effect, and then is going to link it with the loss of cardiovascular function and the death. So it seems that peptidase 3 plays a major role in developing of angiotensin II block and then the shock. And so you want to really measure the level of DPP3 into the blood to understand how severe is the damage of the vasoconstriction that is reacting to cardiogenic shock. This the biomarker has been confirmed of a great utility in monitoring and catch this moment of the progression of inflammatory process in cardiogenic shock within 100,000 patients in many multi-centric studies worldwide. So there is a robust evidence that this biomarker should be used as a test for monitoring the physiopathological molecular mechanism of cardiogenic shock. And in fact, in these acute coronary syndrome patients, in multicentric study, when the patient presented the emergency room with a value greater than of 30 nanogram per milliliter, there is a lot of possibility the patient go to have a severe cardiogenic shock and then to die. We have also shown in our recent paper in critical care that in the emergency room, if no patient coming with a severe news, the level DPP3 greater than 40 nanogram per milliliter is linked with high severity. So it is confirmed that this is a biomarker that is going to mortality into patients coming with severe disease in the emergency room. But coming back in cardiogenic shock, recently we have collected this data in Indonesia when in around 350 patients with acute heart failure we measured DPP3 at the early stage of coming without evidence of cardiogenic shock. And we showed this data are going to be published very soon, that if the patients with acute heart failure present in the emergency room with a value greater than 30 nanogram per milliliter, such we have shown into acute coronary syndrome, there is a possibility to develop cardiogenic shock and then to die. So it is very clear that both in acute coronary syndrome and acute heart failure that are going to represent around 85-90% of the patients that can develop cardiogenic shock. DPP3 is an important biomarker able to showing the inflammatory process, the angiotensin II blocker effect, and then leading to mortality in the patients with the cardiogenic shock. But it is also important to know that from this paper that we show in the Great Network that you don't only want to see DPP3 at the rival, you want also to, because if there is an increase in DPP3 and you are going to do something in terms of therapeutical consequence to reduce DPP3 and you got this result 24 hours after patient's admission, you can have a reduction in mortality. So there is the role of monitoring DPP3 in ICU in patients with cardiogenic shock to improve survival. So we have just said that the cardiogenic shock is the most severe consequence in acute coronary syndrome. During the last 65 years, we have shown that there is a progression in reduction in mortality in acute coronary syndrome because of the use of beta blockers, because of the coronary angioplasty, the stent, and so on. But at the end of the day, during the last 25 years, there was no improvement in patients surviving acute coronary syndrome because many patients still develop cardiogenic shock. What does this mean? This means that cardiogenic shock is our target to improve a patient's mortality in acute coronary syndrome. Guidelines are very clear. In patients that are coming with acute coronary syndrome, that is the risk of developing cardiogenic shock because of latte, because of clinical condition, you definitely want to immediately perform an angiography, coronary angiography and PTCA to improve mortality. Besides performing coronary angiography, you really want to use some drugs in order to improve vasoconstriction, such as vasopressin, norepinephrine, or also in order to improve vasodilatation to reduction of the afterload and then having positive inotropic effect on the heart. And there are a lot of mechanical support circulatory devices that are going to be used recently to try to improve survival in patients with cardiogenic shock. But unfortunately, both intra-aortic balloon pump, both Impella and ECMO, although have been a little bit improvement in outcome and survival, are not really the solution for this patient. Although we still use them, but we need to do something else. So let's work again to try to understand what is the ongoing mechanism in pathological cellular level. And we have just mentioned the role of DPP3, since this is really the biomarkers linked with the inhibition of angiotensin response to the inflammatory process. The good news is that we have this monoclonal antibody, prochizumab, that is going to block DPP3 into the bloodstream and can definitely restore vasoconstriction and then, restore the angiotensin effect and reduce mortality. This has been proven to be of utility in rats, where prochizumab can reduce mortality in rats that are going to be linked with the shock because of the DPP3 increase. And this effect is linked with reduction of inflammatory processes mediated by interleukin 6 or by myocardial damage by troponin reduction. So there is no doubt that it seems that we refuse improving the outcome of patients with cardiogenic shock if we can use this monoclonal antibody against DPP3 in the early phase of cardiogenic shock. The good news is also that these biomarkers is available on point-of-care machine. So in the emergency room, you are visiting your patient with acute coronary syndrome, acute heart failure, or any other reason that patient can develop clinically acute cardiogenic shock. You can test DPP3, and if the value is greater than 30 nanogram per milliliter, you can probably immediately use prochizumab. You can do this even into the ambulance, or when the patient is arriving in the emergency room with the symptoms, you can look at DPP3 and you can start prochizumab to improve patients' outcome and reduce mortality. That is really our goal. So just to conclude, there is no doubt that we should try to do something else in the management and treatment of cardiogenic shock, because still mortality is quite high, around 1 or 2 more patients. And of course, you need definitely to try to reopen the coronary vessel in patients with myocardial infarction. That again is going to be the major reason of patients developing cardiogenic shock, 70% of the patients. But that is also important to understand that there is a kind of initial effect of mechanical support such as Impella or ECMO, but at the end of the day, still something we need to do better. It seems that we are going to use biomarkers such as DPP3. We can catch the physiopathological cascade of inflammatory process, and probably we can do something better. And when you talk about do something better, definitely you want really having a measure in some biomarker to lead to a kind of personalized treatment to reduce mortality in this subject. Of course, biomarkers such as lactate, DPP3, high-sensitive troponin are of great utility, especially DPP3 because it's a monoclonal antibody that can make therapeutic implication to reduce mortality. But you won't use all these biomarkers with the clinical judgment. So my final message to you is that if you are coupling in this very severe patient with cardiogenic shock and imprecise clinical assessment plus biomarkers that are going to let you understanding the physiopathological mechanism at the molecular level, you can have therapeutic decision can in the future probably improve our patients' outcome, improving the survival and decreasing mortality. Thank you again for your attention. I'm so sorry again that I was not able to be there, but definitely we are going to see each other very soon. Anytime you want to contact me, you have my email here. Thank you very much again.
Thank you so much, Professor Uluslararası, for this outstanding lecture. Ladies and gentlemen, it's my great pleasure to invite to the stage Professor Lisa Moreno-Walton. Professor Lisa Moreno is a professor and vice chair of the Department of Emergency Medicine, Clinical Emergency Medicine at Louisiana State University Health Service Center in New Orleans. And Professor Moreno will share with us her perspective on the use of vasopressin in emergency resuscitation. Lisa, the stage is yours.
Thank you so much, and thank you to everybody who woke up so early in the morning after probably having a night of fun. So I need my slides loaded. Nope, not yet.
But it's a good idea.
I need my slides loaded. Oh, perfect. Okay. So today I am going to talk about the use of vasopressin in emergency resuscitation. So let's take a look down memory lane. Well, first of all, in the United States, we do have to give our disclosures, and so those are my credentials, some of them anyway, and my disclosures. None of my consultation or sources of income will be apparent in the presentation, so there are no conflicts of interest. So what is vasopressin? So this is a naturally occurring 9-amino acid peptide that is produced by the hypothalamus and secreted by the posterior pituitary. It's called by two names. ADH is what we pretty much call it in medicine, which is antidiuretic hormone, but AVP, or arginine vasopressin, is the precise scientific name because, as you can see, you know, the structure contains arginine. So it acts on the V2 receptors in the kidney to promote water reabsorption, and that's the primary function of it. And keep this in mind because throughout my talk you will find out why vasopressin was very favorably used and now is unfavorably used in resuscitation. And it all has to do with the V2 receptors and the promotion of water resorption in the distal tubules of the kidney. That is its primary function. It does also act on vascular smooth muscle on the V1 receptors, causing vasoconstriction. And vasoconstriction actually is what the function that you're looking for when you're in the resuscitation bay and a patient is hypotensive, right? So if a patient is in shock, I'm looking to vasoconstrict. I want to raise that patient's blood pressure. And so the secondary function of vasopressin, which says it all right, vaso meaning vessel, and pressin meaning pressure. But I want you to keep in mind the V2 receptors. The promotion of water resorption is what made vasopressin very much come into favor in resuscitation. So I'll give you a fun fact about vasopressin, and that is that over here, as you can see, when a man makes a commitment, whether it's to a person or an idea, he begins to effectively, oxytocin effectively connects with vasopressin in the body, and that connection is critical for men to make commitment in relationships. So that's a little fun fact. So how is it used in emergency medicine and critical care? So vasoconstrictor activity is what you want to increase blood pressure because you're looking to preserve the cerebral and myocardial perfusion. Not so much, right? We don't worry so much, although we care about the kidneys, but you know, we worry mostly about cerebral and myocardial perfusion. We want to make sure that the brain and heart are perfused in patients where we get ROSC, or spontaneous return of circulation. So it's used as an alternative in adrenaline and cardiac arrest and for septic, refractory, or hemorrhagic shock. So for years and years and years, you listen to people, scientists, physicians, researchers present discussions on when to use epinephrine, when to use norepinephrine, and when to use dopamine. And so what is norepinephrine, since we're going into that territory now? So norepinephrine, or Levophed, has had a very bad reputation. It exists as a hormone and a neurotransmitter. It is a potent, fast-acting treatment for life-threatening threatening hypotension, and the sympathetic nervous system is stimulated by it, causing vasoconstriction. So again, you know, we were looking at what we wanted in cardiac resuscitation patients. What is our end game? Our end game is to ensure that there is perfusion, principally of the brain and heart. So why was Leave 'em Dead so bad? I don't know how many people are familiar with this, but initially, when we first, a few years ago, and even back until 2019, when we would start a patient on Levophed, the nickname of the drug Levophed, or norepinephrine, was Leave 'em Dead. And we felt like if we put a person on Levophed, that it was a last-ditch effort and they were going to die. We were always using vasopressin first. And why did that happen? You know, you'd walk into your patient's room in the ICU, or your patient is boarding in the emergency department, and you'd see their feet sticking out from the sheet, and that's what the feet would look at. So people's toes literally fell off, and their fingers literally turned black and had to be amputated. And some people even lost limbs when they were put on Levophed and had vasoconstriction. And why was that? It was because of our own failure to perform adequate fluid resuscitation. Patients ended up having this loss of digits. And so there was also eventual kidney injury because the kidney was not protected. Vasopressin, however, is renal protective, and ultimately these patients died of multi-system organ failure. But what happened in the meantime? The Surviving Sepsis campaign came along, and all of a sudden we were being mandated to give patients massive amounts of fluid. 2 liters of fluid, 3 liters of fluid. So fluid resuscitation became in, right? Fluid resuscitation was the fad. Fluid resuscitation was the mandate. Fluid resuscitation became sexy in resuscitating patients. And then Levophed became popular, because the problem was that when we were using Levophed originally, we were not fluid hydrating patients. And so we were doing fluid resuscitation with the Surviving Sepsis campaign, and scientists and researchers and critical care physicians realized that when you use adequate fluid resuscitation, Levophed is actually an adequate drug and the preferred drug, and it actually was shown to reduce mortality. So all of this had to do with the V1 receptors and the ability to preserve fluid in the kidney. When we give patients fluid, then we don't necessarily need to do that. So are there still any uses for vasopressin? So that's the question that I want to address today. Should you be using this drug at all? So let's look at the 2026 Surviving Sepsis campaign guidelines that just came out this year. So vasopressin does still have a use. It is strongly endorsed as a second-line agent for septic shock, but do not start with it. So what we want to do is make sure that you start with Levophed, start with norepinephrine. If fluid resuscitation, while fluid resuscitation is ongoing in the Surviving Sepsis campaign, in order to achieve a MAP of 65. Now, there is a recommendation in 2026 that for geriatric patients, you need a MAP of 60. The evidence is considered Class C. It's not considered top-notch Class A evidence, but there is evidence there that you can tolerate a slightly lower MAP in geriatric patients. But you want absolutely to have a MAP no lower than 60 for any patient, and 65 is preferable for patients under the age of 65. So that's easy for you to remember. 85% of the experts that weighed in on the 2026 Surviving Sepsis campaign guidelines added vasopressin when Levophed doses exceeded 0.3 micrograms per kilogram per minute. So that's the number to remember. If we're thinking about whether vasopressin still has a role in resuscitation, it does, and the role that it has is as a second-line agent. When you are using fluid and Levophed, and your Levophed dose is up to 0.3 micrograms per kilogram per minute, you tell your nurse when When you're titrating, do not titrate above 0.3. When you get there, come and get me, and I'm going to write an order for vasopressin. So how else can vasopressin be used under the current American Heart Association guidelines? Let's look at cardiac arrest. So in cardiac arrest, vasopressin 40 units, either IV or IO, can replace the first or second dose of epinephrine in the ACLS algorithm. And this has been recommended as a possibility, although many people never did it, but it was recommended as a possible substitution for epinephrine for decades. However, under the new guidelines in 2025, ACLS said that they looked at the evidence, and there actually is no evidence that the use of vasopressin instead of epinephrine for the first 2 doses is not effective. It shows absolutely no survival advantage. And I think that since most of us know that when we're in the trauma bay, a lot of errors can occur when medications are being ordered verbally, drawn up, and then administered, right? There are 3 places where you could end up having errors. It's better to have fewer drugs on the card. It's better to have fewer drugs being handled and passed back and forth. And so to simplify, even though vasopressin did not show a disadvantage, there's no reason to have extra drugs on the card and extra drugs being handed out. And so it is recommended just stay with epinephrine. Just stay with epinephrine from the word go. So studies that looked at vasopressin used in combination with epinephrine and steroids showed absolutely no definite advantage over epi alone. So just remove the vasopressin from the card and stick with the algorithm of just using epi. Now, vasopressin has also been removed from use in pediatric cardiac resuscitation. That was the standard over epinephrine for decades, and that has been removed. And the 2025 guidelines note that there is insufficient evidence to recommend specific vasopressors over others for maintaining a target map post-arrest. So again, the American Heart Association does not, for cardiogenic shock, want to recommend a specific pressor agent. So this is up to your discretion. And so some people are doing sort of a similar thing to what they do in septic shock, and starting off with Levophed, and then sometimes adding epinephrine as an adjunct pressor. But the American Heart Association is very clear that they are not recommending a specific pressor for your use in these patients. So there are also some new guidelines, right, for the use of Levophed in pediatric cardiac arrest. Let's look at those. So in post-arrest shock, so most of us know that resuscitating children is pretty much one of the scariest things we do, right? Unless you're a pediatric emergency physician, even pediatricians are kind of terrified of resuscitating children. And so we want to make sure that we closely follow the guidelines and watch them. So in 2025, the American Heart Association again looked at the evidence for the resuscitation of children post-cardiac arrest, and they noted that an increase in blood pressure and organ perfusion after fluid resuscitation has failed mandates the use of Levophed as the specific and preferred. So while they are not recommending a specific and preferred pressor for adults, they are very, very clear that they are recommending a specific and preferred resuscitation agent for children, and that is Levophed or norepinephrine. So if the child is not responding to fluid resuscitation alone after cardiac arrest, then that child in ROSC is considered to be in post-arrest shock. Fluid resuscitation comes first, continuous IV and IO infusion of Levophed is started second if you cannot maintain the age-appropriate map that you need for that child. And so that starts at a rate of 0.05 micrograms micrograms per kilogram per minute, and you can allow your nurse to titrate, the same way we usually do. Tell the nurse, titrate to my desired map. Now, the thing here though is that your maximum dose is 2 micrograms per kilogram per minute, and this is actually studied. So this is a mandate, a recommendation, a guideline that comes out of research, and it is Class A evidence. You're going to want to have continuous blood pressure monitoring for your child. That's absolutely mandatory, and I think there's nobody who doesn't do that in a post-cardiac arrest child. You want to have central access, and that's preferred, because what is one of the side effects of Levophed that we know, which was one of the other reasons that we used to call it leave 'em dead, because if it infiltrated, we were losing patients to amputation, losing limbs for amputation, because of the fact that not only were we not adequately perfusing to get distal circulation to the level that we wanted, but we're also using a drug that when there is infiltration, and I remember, and some of the more senior people in the room may also remember, walking into a patient's room and seeing that infiltration, and it's very scary, because you know that the tissue is going to start to get necrotic. So for children especially, who have tiny little fingers and toes and limbs, you want to get central access as soon as possible because of the risk of tissue necrosis. So there is validated superiority in the Indian Journal of Critical Care Medicine, and I made a misspelling over there. There is validated superiority of Levophed, which was validated after the guidelines came out in the Indian Journal of Critical Care Medicine, and it was a huge study of over 2,000 patients that were done throughout the country over a fairly long period of time. So this is level 1 evidence that you can count on for the treatment of children. There's also been some innovation in refractory hemorrhagic shock, and I find this really fascinating. I trained as a surgeon first and then an emergency physician, and I can tell you that there was always kind of this thing about you do not use pressors in the trauma bay. You do not use pressors in a trauma patient. You just flood them with fluid, and the next day sometimes they would look like the Michelin Man. But then we did start, saying we're going to limit 2 units of crystalloid, and then we're going to blood. But then we would be resuscitating patients with massive amounts of blood products, and you know that is also not without risk. And so it's interesting that now the American College of Surgeons Committee on Trauma is looking at some of the issues for some innovations in refractory hemorrhagic shock, and looking at Levophed, and actually is showing an advantage. So there is a shift from the stance of strict contraindication, and it's actually looking at the use of pressors early. So we've moved from a situation where we say don't use pressors ever, never, never, to saying that we not only should use pressors, but we should strongly consider using pressors early. So the evidence shows that when standard fluid resuscitation is failing to maintain blood pressure, staying within the guidelines of permissive hypotension. So we're still practicing damage control resuscitation. Damage control resuscitation has not gone away. We still want permissive hypotension because we don't want the wounds that we have succeeded in gaining hemostasis on to all of a sudden bust open and the patient goes back into hemorrhagic shock. So we still are practicing damage control resuscitation. We still want to have permissive hypotension, but we want to strike that very elegant balance between having hemorrhagic control and having adequate organ perfusion. And we're finding that actually pressors are very helpful to us in that way. So we're looking at the use of Levophed actually within 3 hours of the time that the patient arrives to us, and we're showing a 24-hour mortality advantage in patients who get a pressor, specifically Levophed, in the first 3 hours rather than those who end up getting it in 24 hours. And again, when we look at that, it's kind of similar to what happened to us when we were using Levophed and septic shock decades ago, where we waited until the kind of last minute when we were desperate, and we used to say that patient is circling the drain, they're going to die, so now I'm going to add Levophed. So it may be the similar thing that surgeons were waiting until the patient is, I've had the patient for 20 hours and the patient is not doing well, and so I'm going to add a pressor. So those patients don't do as well as when I say, you know what, I'm going to add a pressor, even a low dose pressor, within the first 3 hours of the patient's arrival to my emergency department. This is innovative, but there is clear evidence for it. So speak up in your emergency department if you have a patient who fluid and blood resuscitation are not giving you the MAP that you want for damage control resuscitation. Speak up, talk to the surgeons, cite the literature. This is a new and innovative way of actually saving lives. There are European guidelines that are even suggesting pre-hospital use in the ambulance. This is suggesting. No actual guidelines have been approved in the European arena and not in the United States either. And so we have to keep our eyes open and watch that and see if actually those guidelines become formalized the way the guidelines became formalized for pediatric post-arrest resuscitation by the American Heart Association. So again, the prohibition of pressors in the trauma bay is dogmatic, and we don't need to be following it. And we've been looking at this evidence now for 4 years, and we found that there is no increase in mortality when Levophed is used in conjunction with blood products, not as a substitute, but in conjunction with blood products. So what are the innovative solutions for the use of pressors in resuscitation? Does vasopressin have any use? Not very much anymore. So use Levophed for pediatric post-arrest cardiogenic shock starting at 0.03 micrograms per kilogram per minute, and you can titrate up to 2. Use Levophed for refractory hemorrhagic shock when fluid resuscitation, including blood products, is not enough to maintain permissive hypotension goals. Vasopressin no longer has a role in cardiac resuscitation of adults or children, according to the American Heart Association 2025 guidelines. So when can you use vasopressin? Well, it can be used as an adjunct, second-line agent in septic shock when fluid and Levophed at 0.3 micrograms per kilogram per minute are not achieving a MAP of 65 or 60 in the geriatric population. And you can also give it, based on the fun fact I shared with you, if you want your partner to fall in love with you. That's my contact information if anybody wants to get in touch to discuss this more or to talk about anything about emergency medicine, advancing your career, working together on research. It is my absolute honor and pleasure to be with you today, and thank you for getting up early and listening to me talk. Thank you.
Thank you, Professor Moreno, for this excellent lecture and for the translating complex evidence into the practical messages. And now I would like to open the floor for questions. Yeah, for all of the speakers.
Thank you very much for this nice presentation. I want to give my warm thanks to all 3 speakers. The first question is for Dr. Hikmet. You know, when I was in a residence in the emergency department, it was recommended us to use much more drugs during the resuscitations. It was about 20 years ago. But now, when we come here, many things change. We have just only 1.5 drugs. The first one is epinephrine or adrenaline as needed and antiarrhythmic. And now it is still recommended to use adrenaline or epinephrine every 3 or 5 minutes. That's okay. When we have a prolonged resuscitation, I mean sometimes you need to resuscitate the patient for 40 minutes. In this distance, we have to use at least 8 or 10 gram of adrenaline. And on the other side, we know that it has a very huge ischemic effect. So, do you think that we need to make a limitation to use adrenaline during the resuscitation? For example, 3 gram, not more than 5 gram, like this. This is the question for you.
Thank you. Thank you very much. Dr. Bachet, yes, I think yes, we have to think. Anyway, this is an individualized approach, and the 40 minutes resuscitation is not so common, I would say. Maybe not every day you can see this. That's the individualized approach, I think, should be applied here. And yes, we have to see the response, the heart response for the epinephrine, for the adrenaline indication.
One more to Salvatore. Professor Salvatore, thank you very much. You mentioned about the peptidase 3 markers. It is really very sophisticated new markers. And it happened after a very long time. The patient should have a cardiac failure and perfusion abnormality and tissue failure. But this is a long time. Do you believe that it is a useful and beneficial marker to be used in emergency department or intensive care unit? Thank you.
Yeah, thank you for your question. First of all, again, let me say hello to all my friends there. I'm so sorry that just yesterday I decided not to come because I have a dental issue. But anyway, the question is absolutely very appropriate. Absolutely, we are using DPP3 now in a project worldwide to, select people coming with all severe disease and check DPP3. Before, when the patients come in, our job is not only to make a diagnosis, but also to make a risk stratification. There are evidence that in the emergency room, especially now that we are going to have this possibility with the point of care, if the DPP3 at arrival in many severe patients, you can select whatever you want. I just mentioned about acute coronary syndrome, about acute heart failure for prevention of cardiogenic shock, but you can do also in sepsis patients. So DPP3, once it's going out from the cell, is going to block the react of angiotensin II system and making it a very important inflammatory response. And this is going to link it with the arrival of a shock, okay? So you never know in severe patients which patient is going to have the shock. So my future approach, adding DPP3, will be to select within severe patients at the moment who are the ones that are going to have mortality or bad outcome, including longer-term outcome. So patients arrive, you can do point of care DPP3, look at your patient. If the value is greater than 30 nanogram ml, you have information. This patient is going to have a shock in few minutes, okay? But the good news, and so, I don't like biomarkers that have no therapeutical implication. I think what is good, that if you discover patients with that seem stable, but DPP3 is going to be greater than 30 nanogram ml, you can use the drug prochizumab. And this will be a revolution. And I think that now the mortality of a cardiogenic shock, that is around 50% in our experience, should be reduced. And I think this is the future of these biomarkers that is going to be of great utility for not only diagnosis, because it's not a diagnostic marker, but it's a lot of information for prognostic and making a decision. If the patient is not going to die, you still take more care, so you can make, assume you have two patients with acute heart failure, okay? With the same clinical picture, but in one patient's DPP3 is elevated, more than 30 nanogram ml. You won't admit these patients immediately to ICU. So there is a lot of value in the emergency room. And then just to complete your question, into ICU, you want to monitoring DPP3, because if the DPP3 is going to be reduced, means you are going to have a bad prognosis. I don't know if I was able to answer your question, but I think in the future we have finally a biomarker with a therapeutic implication that is what we need.
Thank you, Salvatore. I have one question to the Lisa. We know that routine vasopressin does not any effect for the resuscitation, but we see some potential effect when we give it. Maybe this is not effect of the vasopressin itself, but a therapeutic effect when we give it with the steroids and with the epinephrine, because we see the study, for example, from the JAMA network, and in this compilation that was increasing the number of the ROS and the survival to hospital discharge with a good neurological outcome. But what do you think? If the current resuscitation guidelines argue against the routine use of vasopressins, it is the problem in the vasopressin, in the drug itself, or at the lack of appropriate population selection? Population selection.
Well, that's always an interesting, and I know you're a researcher, so that's always a question that we face when we're doing research, right? So the selection of the population is critical. And I think that, you know, when we looked at some of the downsides of the use of Levothed, and when there was a ton of research out there showing that we should not be using it, or that when we used it as a last-ditch effort, people died, again, that was all to do with patient selection. With patients that were being studied were the patients that were being put on the drug, and the patients that were being put on the drug were the patients that were already starting to have signs of organ failure. So again, I agree with you that, and to me as a researcher myself, that's always the dilemma that I kind of get into when I read certain studies. I say to myself, yeah, but you know, we don't know whether there's a variable at play that we're not taking into consideration. How were these patients selected? Sometimes it's only one geographic area. That's always the question that you ask yourself. And so I agree with you. I mean, you have to question the validity of a study when you look at how patients are selected. But right now, the other thing we run into is, right, these are the American Heart Association guidelines. And the problem that we run into when we're practicing clinical medicine is that we have to follow the guidelines. If you don't follow the guidelines and you get a bad outcome with your patient, then you're going to be liable because you didn't follow community standards, you didn't follow the guidelines that were published by the authorities, the American Heart Association or the European Heart Association, and so we're kind of compelled to follow those guidelines. But I think that one of the exciting things that happens for us who are researchers and who like that kind of work is it stimulates further inquiry on our part, because even though clinically we have to follow the guidelines, we look at those studies and we say, I'm not entirely sure this was an unbiased selection process, and so I need to do another study. And I know Dr. Pasoma is also in that category, where we kind of like to look at those studies and say, there could have been a selection bias here, and we need to do further studies to increase the, increase the body of knowledge in medicine, and it keeps evolving. And I think that's one of the things that, all of our colleagues agree, that's one of the things that makes medicine such an exciting field, is that there's always something more to study and we can always get better and better. Thank you.
Thank you.
What's that? Dr. DeSoma?
No, absolutely. I fully agree, Lisa. This is exactly the reason why this group is so interested in acquiring new data, right? So absolutely, I cannot agree more, right? And this is a lot of possibility for us to contribute for the future. Just starting for, guidelines are the starting point for research, right? It's not the final, and the fact that every year we have a kind of a new guidelines coming on depends on the fact that you are contributing with the new research. there are so many questions that the guidelines cannot solve. And this is our job as an academic organization to contribute to improve the approach, final design, improving on patients' outcome in critical care. So I fully agree with you, Lisa. Like always.
I know. You and I have been working together for a long time. So, I went to a conference, just to sort of share an anecdote, I went to a conference just a week ago where a speaker was actually talking about how foolish and how stupid the American College of Surgeons Committee on Trauma was, because they used to recommend, doing a rectal exam on every single patient, and they used to recommend this and that, and how foolish and stupid that they were. And I felt compelled, I had to get up and make a comment and say, there really is nothing humorous or anything shameful about the fact that medicine advances. We used to not believe that we should wash our hands between patients until Semmelweis said, oh my God, doctors are killing people because we're not washing our hands. So the beautiful thing about being in the fields that we are in is that we're constantly learning more and getting better and increasing survival and increasing longevity for our patients. And it is conferences like this where we all get together and start talking, and we can do research projects together so that, to your point, we have an unbiased selection. We have people from Poland, people from the United States, people from England, people from Turkey, people from Uzbekistan, and we can do these groups like this, groups like EPAT, groups like WASEM, allow us to get a sample of patients from all over the world to really see what works. Not just what works in my hospital, not just what works in my district or my country, but what works globally to increase longevity and to increase health and to increase the quality of life and to increase the survival rate for all patients. So, it's an honor for me to be here, and I'm just happy that I get to meet more and more people each time I come, and we get to do more and more research together. So thanks very much.
Is there any other questions to our speakers? So now we...
Thank you. Can I have one question, Dr. Moreno? One of the biggest problems with the research in resuscitation setting is you cannot do placebo-controlled trials. So it's possible that whenever we do a trial between two, drugs, we control placebo with placebo, And recently in Lancet there was a really nice trial about intubating trauma patients at the place of the trauma, using AI also to correct for all the determinants which may skew the results. I think we should not only do research, but we should come up with a way to do research differently. Because what you said about pre-hospital administration of vasopressin sounds really plausible. Because the earlier you start, the better. So I think not the traditional way of doing research, but we have to come up with our own way, also using modern techniques. I don't know what you think about that.
Well, I thank you so much for that question, because I think it's a fabulous question, and it speaks to some of what Dr. Ma was talking about yesterday. So I think that two things that are very innovative in research now, and one of them is something Dr. DeSoma does in looking at longevity. He looks at populations, and rather than intervening and doing something to them, he looks at what they have been doing themselves that has resulted in longevity. And so we have to take that approach too. Since we cannot in resuscitation conscionably and ethically do placebo-controlled trials. Just like in cancer, you often can't, like the tamoxifen study had to be stopped early because everyone who was not on tamoxifen was dying, and people who were on tamoxifen were doing great, right? So there are ethical issues that take place for us as researchers. And so if we cannot do placebo-controlled trials, we need to look at what's being done in different areas. What's available in this country, what's available in that place, and what we're actually doing, and compare what we're doing, just like in the longevity studies, with the survival rates. But you raised AI, and Dr. Ma talked about that too. And so now many of us who are practicing physicians feel like we are compelled to follow the guidelines, even when we are not so certain that the guidelines make sense. For example, tourniquet use, that to me never made sense, and yet we were having to put tourniquets. Now we don't anymore, but we were having to put, tourniquet use is good, right? That makes sense, and when we were told to stop using tourniquets, that didn't make sense. But we had to do what the guidelines said, so that if there was a bad outcome, we could say, I followed the standard of care. But now we have AI, so how is that going to change the way we do research? If all of this data is getting put into the computers, and AI is now analyzing not just the one hospital's output, but the entire country's output, like you can do in countries like Canada and many countries in Europe that have a national health system, where you have the records of every patient who has ever come in with that diagnosis. Every patient who has ever come in, with an ankle fracture, that's how you got the Ottawa ankle rules. Are we going to get similar results when we have AI actually analyzing what different doctors did in different situations, who lived, who died, who had a good quality of life? Because I know that's what some people focus on, right? It's not just whether you live, but the quality of life that you're left with. Dr. Janar looks at that in geriatric patients all the time. And so AI is going to, I think, change that. It's going to give us more permission, if you will, to be broader in the way that we treat patients, because I think the face of research is going to change. It's not going to be so much us designing studies as AI looking at what we do and what the results of that are.
Can I add something to this comment?
Please do.
Yeah, I really like, I think that the question was raised from Rabat, right?
Yes.
Rabat, okay, so that makes a lot of sense. Yeah, I fully agree that in the future, in acute setting, even when you are thinking to introduce a new drugs, you don't need anymore to use placebo. Let me tell you what we are doing practically, try to include prochizumab in the treatment of cardiogenic shock. The trial we are carrying on does not include placebo control. If you are going to have the standard of care, and I am part of IRB, and we definitely say, okay, what is the value in acute setting? Out of chronic diseases, another story, okay? But in acute setting, if you are doing a group with the standard of care, okay, whatever it is the disease, sepsis or acute heart failure or cardiogenic shock, acute coronary syndrome, then you have a control with the group that is taking the additional value. And also for the patient to sign informed consent is much easier. Don't have the concept of placebo, right? So I don't know if this was your question, but definitely I see the value. Don't do anymore the need for placebo in the acute setting of such as the disease we are facing for, but just having a group. And this is the way it was admitted, the SGLT2 inhibitor recently. They don't use placebo. They just use the SGLT2 plus the standard of care. I don't know. I would like also to have from Rabat his answer about this position, because this will be in the future the way we have to design the trial. What do you think, Rabat?
Correct for confounders, which we cannot correct because the randomization is not there. And then placebo can be, of course, replaced by something else as long as you correct for the confounders. And you know, the regression to the mean principle, if you can take it out. So I think we should sit down one day and think about doing studies in this setting and come up with our own way. You know, the traditional way of doing one group against the other and p-value, it's not the way to go. You know, so I agree with you, Sal, and we've got to refine it more.
Yeah, I think for all of us that's changing. We're being challenged in the way we think about designing studies. And I think this may be something, why don't we get a work group together? I mean, seriously, that's what the purpose of a conference like this is. We should get a work group together, a task force to start to look at this and brainstorm about it, and maybe publish an article suggesting that the face of research needs to change. I think that would be great.
Just one thing to add to that. So, you know, I do a lot of public health research where, you know, it's very hard to kind of say when I do a public health intervention, did I have, you know, and then some result happened, is it just correlated or did it cause it? So we will try to find a counterfactual. So for instance, you know, if you look at multiple cities during COVID, those who sheltered in place, those who didn't, and you want to kind of say, did it work? You have to try to identify another population that's as similar to your city, but that didn't do that public health intervention, and then you sort of use that as your placebo, your counterfactual. And so we're looking at ways for AI to help us do that. So like in New York City, when I can say, okay, we took our population, we did shelter in place, this is how it affected the curve of COVID, and then we use AI to try to find another city that looked similar, had similar, you know, comorbidities, similar patients. And now, you know, but a city that didn't do shelter in place, let's look at the trend. So kind of taking that into things like this where we want to, you know, use AI and say, okay, I'm doing a study where I've got this type of patient, can you, and we're doing this intervention, can you find a group of patients and match them as closely as you can so I can have a counterfactual cohort of patients? And it can be from, you know, all over the world or within my city or whatever that looks like, but kind of taking this use of counterfactuals that we use in public health and start applying it to more things like this. But we need things like AI to really help us match, you know, our population as best as possible.
So I really like what you said, and I think it feeds into the whole concept of looking at the way we do research. So seriously, I'm going to put out a request for anyone who wants to join a work group, and let's just write a qualitative descriptive paper about the potential for research to be changed as AI slowly develops, and I think that would be a great idea. Brilliant ideas come when brilliant minds come together, right?
First of all, we're really honored for your presence here and get you from your experience in the field of emergency medicine and also for the presentation. Actually, my question is going to be very short. Personally, I had this case in old woman. She was a ER to ICU border patient, a pneumosepsis patient, and she was falling from the cliff. I was losing her actually. Her blood pressure was falling. She's on Levoped. We call it steroid in Turkey. I'm not familiar with the name Levoped. The drip was a maximum, and I remembered something. That was about 3 years ago. I remember something about using of the steroids in patients with sepsis. So I said, let me try. Let me give it a shot. So I gave her 120 milligram of prednisolone. I have nothing to lose. I have to try. Her blood pressure started to rise, and at the evening I gave her the other shot. And the other day in the morning, the Levoped drip was off, and 1 day after, this patient was discussed to be, are we going to take her to the ICU or to the ward? That was really, really terrific to see the effect of the steroid in such patients. My question is, are we going to see the steroid as an official element in the guidelines of the sepsis survival campaign, or at least as a popular clinical strategy in the emergency medicine and critical care units? Thank you.
Yeah, so I would invite anybody else to join in on this too, if they have a different answer than I do, or a better answer than I do. When I looked through the 2026 guidelines, I did not see that they did not actually analyze any of the studies and the data on steroid use. So, but you know, steroid use is up there, right? It's something that we definitely consider doing. And there have been studies in the past, as were referred to, on the use of vasopressin, levophed, and they're telling me our time is running out. But it's a fascinating study, so to keep it short, as far as I know, from me looking at the 2026 guidelines, they didn't look at it, and that would be a letter worth writing to say to them, you ought to look at it for the 2027 or 2028 guidelines. Sal, do you know anything different than I do?
Yeah, no, very good point. I really enjoyed this question. Let me tell you what is
We
my
are sorry,
position.
but if we can, let's talk like outside, because even the organizer said that we just finished the time, even the coffee break time.
All right.
Okay.
So they want us to go for coffee break, but
Yeah, somebody can tell me that I am a biomarker guy, but in this case, I would like to check the effect of corticosteroid in sepsis on procalcitonin reduction. That's okay. Just make it.
definitely. This was a great discussion. Thank you, everyone.
Thank you so much for this excellent discussion, and 1 minute ago we started the next panel, so thank you.
Thank you. Bye. Bye. Enjoy your time in Antalya.
Yes. We got to start the session at 10:30. I don't know whether you have. Oh, yeah. Yes, sir. Ladies and gentlemen, we're going to start the next session. So would you take a seat? Is Gabriela here? Okay. Because Qatar, we are having two speakers from Qatar. Gabriela, shall we start the session? Gabriela is an emergency physician fellow. She's going to talk about a very important topic about stop the bleeding. So Gabriela, Gabriela is, as I said, an ED physician from the Netherlands who is in training in a second year, and this project she's going to describe is one of the PhD track, right? Gabriela, you can start. Please.
Hello? Perfect. My name is Gabriella Visser. I'm one of the training EB members and also a PhD student. And I'm very honored to talk here today about a part of my PhD project in which we are comparing the combat application tourniquet to two new different types of tourniquets in untrained lay people. Trauma causes about 5 to 6 million deaths per year globally, and life-threatening bleeding is a major cause of preventable death in trauma, leading up to the leading cause of death for young people between 1 and 46 years of age. A recent article published in the British Journal of Surgery by Mia Wan discussed a whole year of trauma calls for their hands in London, and assessed all the people that had died in the trauma calls that they had. And in the whole year, almost 500 people died. Of that, almost 80% died before reaching the hospital. The main cause of death in these people was hemorrhage. A person can bleed to death within 3 to 5 minutes, so timing is of the essence. We rely heavily on ambulance, police, firemen to come to the aid of these people, but they are often too late. So in the Netherlands we have the rule, ambulance has to be there within 10 minutes, which is often too late. So lay person intervention is essential in these cases. Therefore, the Stop the Bleed campaign has been initialized in the US and also implemented in the Netherlands and many other countries. And part of the Stop the Bleed campaign is that we teach people to use a tourniquet. The one we all use is the combat application tourniquet. It has proven its point, it works perfectly, but you need training in order to apply it correctly. More and more different types of tourniquets are being brought to market, and some of them are also aimed at lay people. For example, the First 15 tourniquet is a tight band, a Velcro band that you wrap around itself until you stop the bleeding. So it is basically just one step, doesn't require any training, and they advocate it should work in lay people. A different tourniquet is quite similar to the cut, is the Dnipro Gen 2. This comes from the Ukraine, and they made it their own tourniquet, but made simple adjustments to improve it. And a different tourniquet we are planning to work with is a fully automated tourniquet. You just press a button and it blows up and stops bleeding. What we did is we went to several different shopping malls in Amsterdam, in the Netherlands, and recruited lay people who had no prior training and randomized them in 2 different groups. We compared the cat to the Dnipro and we compared the cat to the Afferent. People were then randomized to either start with the cat or the other tourniquet, and then they crossed over in order to see results within one person, the differences. Exclusion criteria were previous knowledge or training or the age below the years of 18. For this, we used the task leg trainer, which is a leg that we attach to a pump, and we can simulate a bleeding through 3 different types of wounds. And then via an app, we control the bleeding, so arterial or venous, and the amount of flow. So for this, we chose arterial to make it look more real-like, and we chose for a bleeding of 250 milliliters per minute. And the lower bar that you see there is an indicator of how much pressure is applied to the wound, and the app shows you when occlusion is obtained by the layperson. Before trying to stop the bleed, we asked to fill out some questionnaires, demographics, and also Likert scales with regards to self-reported confidence, willingness to help, and also their own health. We measured their grip strength, and then we asked them to stop the bleeding in the leg with the 2 different types of tourniquets, using only the instruction manual that was supplied by the manufacturer. And then afterwards, we asked them to fill out the questionnaires again to see if there's any difference before and after testing. Primary endpoints were success rates, so successfully stopping the bleed, and also how long it took for them to stop the bleed. And we ended the scenario at 5 minutes because in real life that's when the person would have been perished as well. And also we were quite interested to see if the people themselves had any tourniquet preference after using them, and if anything changed in their confidence or willingness to act before and after completing the tests. In total, we were able to include 54 participants, 31 in the CAT AFRA group and 23 in the CAT Dnipro group. This is the demographics of the 2 groups together, so slightly more females than males participated. Mean age was 43, so ranging from 19 to 70 years old. And what we found striking is that the major part of the people who were willing to participate had a higher education, so either college or university, which is not a good representation of the population in the Netherlands. And the grip strength we found 31.4 kilograms. All of these demographics turned out to be non-confounders, so they had no influence in the test results. With regards to the primary endpoints, the CAT was actually quite successful, so 58% of the people were able to apply the CAT successfully versus only 14.6% in the AFRA group. And this difference turned out to be significant. We could not find any differences between the CAT and the Dnipro group, probably also because they're quite similar in design. With regards to timing, CAT was also not more successful, but also faster than the AFRAT. So it's mainly 2.5 minutes versus almost 4 minutes to apply the tourniquet. And between the Dnipro and the CAT, we also found some differences. And the Dnipro seems to be quite faster than the CAT. And what we also observed in this group is that there was actually quite a big learning curve. So the second time that people were asked to apply the tourniquet, they were almost always faster than the first time they did it. And we could not see that difference between the CAT and the AFRA group. Reasons for failure we noticed: incorrect positioning, so below or on top of the wound, or taking more than 5 minutes to stop the bleeding, missing certain steps, and what we found is that the AFRAT consistently was applied too loose and wasn't able to successfully stop the bleed that way. Then looking at the secondary endpoints, when we asked preference, about the preference, participants strongly preferred the CAT over the AFRAT, but couldn't really decide between the CAT and the Dnipro, were equal in the opinion about that. We asked people to fill out the Likert scales. I put example because sometimes it's a bit difficult to read the numbers. But we asked them to either strongly disagree all the way to strongly agree, and then we numbered them. So strongly disagree was given number 1, and then strongly agree number 5. When we asked them about confidence in recognizing a life-threatening bleed, before the test they gave it a general 2.5, and then after it changed, so it went up to 3.15. This difference was significant, and also their confidence in correctly applying the tourniquet changed for the better after completing the tests. And this is actually also found in several other studies. their willingness to act was already quite high, so they already scored themselves a 3.5, and it changed for the better a little bit, but the difference was not significant. So in this test setup, using the leg that we have, here you see one of our participants, the cat seems to be significantly better than the F-rat, not only in success rate, but also in timing and layperson preference. In the Dnipro, they seem equal, but somehow the Dnipro was applied faster than the cat across all groups. One thing I have to say is that for the Dnipro group, we haven't yet reached our sample size, so numbers could change maybe a little bit. What we found striking was the high education people had, so maybe there's somehow is a selection bias, although we try to invite everybody. People sometimes mentioned to be hesitant to participate because their Dutch wasn't good enough to fill out all the forms, and therefore they retracted from the study. I think this study shows again the importance of training and hands-on training. Although people were successful, it was only 58% of the people who were asked to apply the CAT that were successful, and it took them quite a long time to stop the bleeding. But you see already, if they practice it once, their confidence rises and their willingness to act also changes for the better. And I think it also shows that the design of the tourniquet really does matter if it's intuitive or if the instructions are clearer than they are now. It could help the lay people better apply tourniquets and stop the bleeding when something happens. Questions?
Thanks, Gabriela. Very interesting. Any questions? I got to think about external defibrillators which we use in. This is something like that.
Yeah.
Are you planning to do a public health campaign about it? Or, I mean, you can do tests. You know that this works. I think the only question is, can public use it easily? What are your plans to spread it around this? Let's say something happens in a football stadium or something.
Yeah, so I think it would be very good to have a stop the bleeding kit next to every AED. And in fact, we had an incident, I think 2 years ago in Rotterdam, in one of our hospitals, where there was a person who started a fire and started shooting at people. And since then, they actually implemented the stop the bleeding kits into the AED kits there as well. And I know we have in the Netherlands, it's called burgerhulpverlening. I don't really know if they have it in different countries as well, but people who are at home, they can receive a text if somebody needs resuscitation, so you can maybe be there faster than the ambulance is there. And they're looking into seeing if they can call upon these people as well if there's a trauma, so not only resuscitation.
Yeah, resuscitation, in Netherlands, every person, if you get a heart attack, has to have an AID, external defibrillation, within 6 minutes. And somebody has to be there, so that you can do.
Yeah.
Anyway, we got more time for one more question. Yeah, please.
Okay, thanks for the nice presentation. Regarding the size of the tourniquet, did you consider the morbid obese, the size for morbid obese? Can it be applied?
No. So I think even with the morbidly obese in the hospital, what we use is a combat application tourniquet. The F-red, I think, would be suitable for the morbidly obese because it's broader in width, but it's also quite a long band. So what we noticed is participants were hesitant to apply it because you need to wrap it around the leg, and then splatter comes into your face every time. But I think for a person who is obese, it might actually work really well, the effort. Yeah.
Yes, please.
Thank you very much for your presentation and your good study. You did this study with advanced requirements, advanced devices. It's okay. It would be very much better to use the normal devices to teach this advancement to the community, the population, because it's really very difficult to find advanced devices when they see any patient with bleeding. So I appreciate you. This is really, really very needed because the patient who have bleeding when come to emergency department, we can manage it. There is no problem. But the problem is outside.
Exactly.
Outside setting.
Yeah.
So we have to work on this issue so much. Thank you very much for your reminding.
It's a good point. Very good point. Thank you very much. Gabriela, thank you very much for your presentation. Brilliant.
Thank you.
I think we're going to now.
Yeah. Thank you very much, Dr. Gabriela, for your good presentations. Next, in the session, trauma sessions, we have gotten great speaker from Doha, Qatar. I would like to invite Dr. Hassan Al-Tahani from Doha and Qatar. Hassan Al-Tahani. Yeah. Hassan Al-Tahani is the
Good
head of
afternoon.
Travma
I'd like
in
to
Hamas
thank the
Medical.
organizing committee and the society, the IBAD, the Emergency Physical Association of Turkey, for their kind invitation. And I'm actually missing the meeting and missing being with you in this outstanding meeting that we usually enjoy every year. Especially thanks to Professor Bashar for his kind invitation and organizing committee. My name is Hassan Al-Thani. I'm from Doha, Qatar. I'm going to present today on the laryngotracheal injury management and outcome based on our local experience in Qatar. I have nothing to disclose regarding this presentation. My objective is to have a review addressing the laryngotracheal injury management and the outcome in the trauma patient, and highlight the local experience in our hospital in Qatar. Laryngotracheal injury have a high mortality rate, although they are infrequently seen, typically associated with multi-system trauma. An accurate and prompt recognition of the laryngotracheal injury is essential for the best outcome for the patient who sustain these injuries. The anatomy of the larynx and the trachea is, in my opinion, sophisticated, and we unfortunately mislabeling the injury when it comes to the trauma. The larynx boundaries start at the epiglottis and end at the start of the trachea. And the trachea is two components, a cervical part and the thoracic part, the middle part, and then the left and right main bronchus. And the larynx has a very important function, not only for the vocation, because the presence of the vocal cord, but also in coordination of the aeropharynx and aerodigestive pathways for these patients. Entry in the larynx account for less than 1% of all trauma entries. They are rare but can be very serious. It is the second most common cause of death in patients with head and neck trauma after intracranial injury. And the etiology is typically blunt or penetrating. In our region, blunt injury accounts for the highest percentage of injury, and the degree of the severity of the blunt injury depends on the force applied and the surface area. Therefore, the sharper the objects that hit the larynx, the higher force that can apply to it. The penetrating injury usually are divided into low velocity penetrating injury like knife wound, or high velocity injury like hunting or military rifles. This case, although we were addressing the watercraft related trauma, we had a young 17 years old boy who actually sustained what's called clothesline injury to his neck. He was riding a jet ski and hit the rope which anchoring a boat in the sea, resulting in an open wound and a avulsion of the trachea from the larynx, resulting in intubation through the opening in the trachea, the neck, at the sea, and also the patient sustained a complete occlusion of the right internal carotid artery and suffered a massive intracranial infarction related to this. When we evaluate the patient, it depends on the history and the physical examination. The history, we look at the mechanism of injury, but also looking at the history of the anterior neck trauma. Searching for a change in voice or hoarseness, pain related to the anterior neck, dyspnea, dysphagia, and subcutaneous emphysema. On a physical examination, the physical examination will follow the ABC, looking at the airway mainly, but also addressing the striders, the voice change, and to rule out also concomitant cervical spine injury. To evaluation in terms of imaging, chest X-ray is the simplest, and this chest X-ray illustrated in this boy who sustained this injury that he sustained also bilateral pneumothorax, requiring insertion of the chest tube on the right side and two chest tubes on the left side to treat his bilateral pneumothorax. The CT scan is the modality of choice in these imaging that give full detailed information about the subcutaneous tissue. It can be reconstructed for bony component, assess the cervical and spinal cord, as well as the vascular, and in this image we can depict the total occlusion of the internal carotid artery in this patient. Direct examination by flexible laryngoscope or endoscopy and esophagogram is usually done in a later stage, but flexible laryngoscope or rigid laryngoscope, it can be done in the emergency room as we evaluate the patient for intubation. There is a number of classification system for laryngeal injury, which make it really difficult in terms of different trauma surgeon or ENT surgeon labeling the injury and grading the severity of the injury. The gold standard one is Shaver classification, but sometimes people use the anatomical classification, the mechanism-based classification, cartilaginous fracture-based, computer tomography classification-based, endoscopy, looking at the mucosal classification-based, and functional outcome-based classification, looking at voice and air, as well as the laryngeotracheal separation classification. These are some of the classification systems that have been described in the literature. And this table summarizes actually the advantage and the disadvantage and the limitation, and we will stick with the golden standard classification in our review for this patient groups with injury. Our study is a retrospective study looking at the trauma patients who were admitted between 2010 and October 2025 with laryngeotracheal injury. We had 121 patients with laryngeotracheal injury. The age, the mean age is 33 plus or minus 12 years. The majority, almost 97% of them are male patients, and also 74% of these patients are sustained blunt injury, with a small percentage of the patient sustained a penetrating injury, nearly quarter, and burn is accounting for less than 2% of the injuries. The mechanism of injury for the blunt, traffic-related injury account for 1/3, 31%. Self-inflicted and suicide, unfortunately, it's high. It's 20% of the fall from heights account for nearly 11%, and pedestrian accounting for 12%. And the rest are a small number, and we can see that assault and gunshot is accounting for 7%, and stab with a knife is 4%. So penetrating injury accounting for nearly 11% in total. The framework injury, which include the thyroid cartilage fractures, accounting for 43.8%, which is really a large percentage of for this group, this cohort, and community fracture accounting for 15%. And these are mainly with a patient who had self-inflicted hanging or suicide-related injury. Cricoid cartilage fractures accounting for 27%, and hyoid bone fracture is nearly 10%. Glutic injury is smaller, it's only 4%, and subglutic injury accounts for 23% of these patient involvement. The Shepherd classification was clearly illustrated in only 43% of the, 43 patients, and the majority sustained either minor or intermediate, so grade 1 or grade 2 injury with severe total isolation of the trachea from the larynx accounts for 1% of, 2% of the patient. The pre-hospital arrest was in a high percentage of the population. Hospital arrest with a patient who sustained actually hanging and suicide attempt. And the vital sign of now significant usually for these patients. The activation level is level 1 activation by the ambulance service, which means that these are a serious patient accounting for 70% of the patient. A small percentage of the patient had alcohol positive, nearly 14% of the patient. And the revised trauma score is not high, it's only 7, with a threshold of 0.9. And cardiopulmonary resuscitation and account for 27%. The injury severity score is high, it's accounting for 24 in general. The abbreviated injury score is significant for different regions, and there is a high association with this injury related to head, chest, abdomen, accounting for nearly 30% in the head, 40% with with a chest injury and 11% with abdominal injury. The cervical spine involvement accounts for 14% of these patients, and the thoracic is 4%, and lumbar is 6%. So, looking when we examine and treat these patients for concomitant spinal cord involvement is very important in addressing these patients. 8 patients went for laparotomy with also the neck injury. A direct tracheostomy as a treatment was done. Patient vascular injury requiring either intervention or conservative management at 12% of the patient, and for 6% of the which accounts for 5% of the patient, and 1 patient underwent ECMO with the management to stabilize him. The main management criteria for these patients in general was repair in 91% of the patient, primary repair and tracheostomy in 4.3% of the patient, and primary repair of the bronchus was in 1 patient, and 1 patient required a stent, and this patient is the patient who was also requiring ECMO management. The activation of massive transfusion was done in 9% of the patient's requirement, and actually blood transfusion was in also. So the need is high in this group patient. Severity of the injury. Emergency is a very short stay, and the length of hospital stay median is 7 days, but it ranges between 1 to 260 days. And also the length of the stay is long as 5 days, and range between 1 to 45 days. And 2 days ventilation days in average, and it ranges between 1 to 27 days. The outcome for the surgical repair, leak was encountered in 1 patient, which was treated conservatively with prolonged intubation and actually healed. 2 patients developed empyema. 3 patients had airway stenosis, which was managed conservatively, and 4 patients developed endobronchial granuloma, granulated tissue and granuloma, which require bronchoscopy and resection. Very small percentage of patients had complication in hospital, which include ARDS in 2.5% of the patient, ventilation-associated pneumonia in 2% of the patient, and sepsis in 2% of the patient, and CLABSI was patient. But mortality was significantly high, as 33% of the patient died from this injury. Vocal cord injury was sustained in 8 patients, and recovery and the follow-up of the vocal cord was observed in 3 patients, which account for 37.5% of the patient. And the duration of follow-up is 46 days, but it ranged between 1 to 4,249 days, reflecting that some of our patients are actually non-native, and they leave the country after recovery. This is actually our paper addressing the 3 cases who were managed by ECMO, sustaining a tracheal injury and requiring ECMO support for their management. And more recently, we had also published this paper addressing tracheal management surgically and conservatively with 2 case reports. To conclude, this injury mechanism is predominantly in our group is blunt injury, accounting for 74% of the patient, and traffic-related incidents represent the single largest etiology categories. The follow injury related to this is the self-inflicted and suicide-related injury, accounting for 20%. And therefore, this distribution underscores that the injury is primarily considered a high-energy deceleration and direct cervicothoracic impact resulting in this injury. Also, the application of Shaver classification system to the larynx injury has a direct implication for the management in our group. The low grade is managed conservatively in the majority of the patient, and high grade require complex surgical reconstruction. And the last conclusion is related to the outcome. The substantial morbidity and mortality, despite the general favorable prediction of survival based on the trust estimate, is a reflection of the underscoring difficulty of highlighting the importance of early detection of this injury. The function recovery is 5% of the patient for the vocal cord demonstrate a recovery on the follow-up, and this need actually a close follow-up for this patient. This injury also a resource intense utilization based on requirement for massive transfusion protocol, the long hospital stay in comparison to other injury, and also the need for 5 days admission to the intensive care unit. In hospital, mortality is quite significant. It's 33% of these patients due to the associated injury in the head, chest, and spinal trauma. With that, I would like to thank you again for the opportunity to present, and I invite you to join us in Qatar Health 2026 in November, the 11th and 14th, which address the advance in surgical care through integration and innovation. Thank you.
Thank you very much, Dr. Altani. Always a pleasure to listen to. Yes, we got 2 questions already. Please.
Thank you very much, Dr. Hassan, for sharing these very nice cases, and very much thank for your addition to the literature. MashaAllah, you have very different cases related to trauma. But I have a very short question. Your mortality was about 33 points. The question is that all of them happen due to tracheobronchial injury or isolated tracheobronchial injury or the other system injury?
Professor Bahjat, it's been a really hard time for me and the group not to be with you guys. These patients who actually die, had high mortality, had also a pre-hospital cardiac arrest. And mainly they are the one who sustain hanging suicide attempt. So they have comminuted fracture of the cricoid and also thyroid cartilage. So they are the one accounting for the high mortality. So it is related to laryngeal trauma direct rather than the systemic injury.
Thank you. There's another question. You got another question? Come here.
No, it's unavailable now. Speak microphones now.
Thank you, Dr. Thani, for this nice presentation. My question is, number of cases where the only cause is the tracheal, the isolated cause. Were you able to analyze them or subgroup them?
So yes, we did actually analyze only the trachea. So that we divide the injury of the trachea into two sections, the cervical portion and the distal portion. They are actually a small number for the endothorax injury, and we actually report them in a different paper. But the intrathoracic tracheal injury are usually severe, require a complex procedure and management, and we had 4 patients require ECMO support during the procedure, and we had 2 mortality in this group. They are not included in this study, but one before and one after the study. And we include one of these cases in the study, the current one. The the cervical tracheal injury are usually suicidal majority or penetrating injury due to gunshot, and usually these are, if they are isolated to the trachea, are managed much easier compared to the endothoracic, thoracic component of the tracheal injury. So we actually did analyze them, but I didn't separate them in this presentation.
Thank you very much. Any more questions? I was just wondering, you were talking about the resource utilization. 7 days of hospital stay in such a severe injury sounds like pretty short. Is it because the post-hospital arrangements are much better in Qatar than other places?
Thank you for the question. No, when I compare them to the overall hospital stay for our trauma patient, is currently 4.6 days, and these patient 7 days, so almost double the others injuries that, although we, in a blunt injury, we see a lot of severe injury.
Yeah.
Overall, when I compare this number to the other injury, they actually require at least 3 days extra. And that's why I consider this, resource intensive. Plus, ICU stay is longer than our current cases. So that's the 2 components.
Thank you very much. There's another question. Please.
Dr. Hassan, good morning. Thank you very much for this presentation. It was really a very nice study. But my question is concerning about the laryngeal post-traumatic vocal cord paralysis. When the patient wakes up, everything's okay, but the patient is mute. Do we have any data analysis about post-traumatic vocal cord paralysis as an outcome? Because I've seen many of my colleagues having a very hard time in courts where cases are filed for iatrogenic post-intubation vocal cord paralysis. We can't get them apart. Is there any outcome? Is there any significant correlation between the trauma and the post-traumatic vocal cord paralysis? Thank you so much.
Thank you. In this cohort, we, record 8 cases, and out of the 8 cases, 3 cases had a full recovery in the follow-up. So we left with 5 cases, one with complete bilateral vocal cord requiring trachea for the rest of the life, and the others have either unilateral or partial, did not require a tracheostomy, but they need a long-term follow-up with the speech therapist. It's very difficult to presume that these patients have a vocal cord disease or pathology prior to the trauma, so we consider this as a trauma-related. The question that is this related to the intubation or intervention or the direct trauma is very difficult to say, but since they come with a trauma and requiring the management, we consider it it's trauma related, not iatrogenic. And that's why we cannot distinguish it, but we consider it traumatic related rather than iatrogenic, not because the prolonged intubation, because if it's prolonged intubation, it can recover. If it's difficult intubation, which can happen, result in injury to the vocal cord, usually these patients, will be in a different situation. But unfortunately, for direct laryngeal injury, vocal cord will be, most likely a primary related to the underlying, related to the trauma itself. And that's what we did not come across, a court-related issue in this regard.
Thank you. Thank you very much, Dr. Altani, for this presentation and for answers. Always good to listen to you. Thank you. Have a great day.
Thank you, sir.
We are staying. Thank you very much.
Thank you. Thank you. Thanks, sir.
Thank you.
We are staying in Qatar. You want to introduce?
Yeah.
Okay. Please.
Thank you very much for Dr. Altani. And the last speaker from the trauma session, I would like to have the honor of inviting Dr. Ayman El-Manyar. He's from Doha, Qatar. He's a cardiologist also, and he's the head of the Research Center Vascular Surgery. And he will give the topic with the title of Bradycardia in Trauma, What Does It Mean? And let's start with I am Hassan El-Manyar from video recording. Yeah.
Good morning. I would like to thank the organizing committee for giving me this opportunity to participate in this conference. My presentation is about the bradycardia and trauma. What does it mean? So I am going to discuss the diagnosis and the application of slow heart in trauma patient. I have nothing to disclose. So if you are in the emergency department and a patient is coming to you who sustained a traumatic injury, what do you expect his heart rate to be? It's normal or bradycardic or tachycardic? And the majority of people, when they exposed to trauma or stress, they have tachycardia. But the people who came with normal heart rate or bradycardia following trauma, actually it is misleading for the emergency doctor because he may ignore that the patient had severe or significant internal bleeding and he expects tachycardia in bleeding. But if a patient came with normal heart rate or bradycardia, he may think it is not the event of internal bleeding. So normal heart rate, bradycardia in trauma patient is misleading for the emergency department team. In most people, once systolic blood pressure decreases for a reason such as internal bleeding, the heart rate will start increasing as a compensatory mechanism to maintain the cardiac output and organ perfusion, and this has also a limitation. Therefore, bradycardia or slow heart rate is not a usual response in most subjects sustaining traumatic hemorrhage, because in almost 1/3 of people, tachycardic response to bleeding is absent. So 1/3 of us will not respond in the appropriate way. There is no tachycardia with bleeding. This is called the low tolerant group. In those patients or these people, the parasympathetic is the dominant. This will reflect the dissociation between the heart rate and systolic blood pressure. Therefore, identifying the cause and the type of bradycardia is clinically important. Their implication as a cause and as a type will differ, and being time sensitive. So the type of bradycardia, there's two types. The true bradycardia result from underlying physiological or pathological cardiac disorder. So the main pathology is the heart. So this is called true bradycardia. But bradycardia with massive bleeding is attributed to physiological phenomena called relative bradycardia. So again, true bradycardia, to know the cutoff, the heart rate is less than or equal to 60 beats per minute and originated from the heart. Relative bradycardia, which is inadequate heart rate response, the definition is varying from study or from author to author. I mean the cutoff to define the relative bradycardia. The cutoff can be 90 or 100. Heart rate in the first situation, the heart rate is less than 90, systolic blood pressure at the same time or simultaneously systolic blood pressure also less than 90. In another scenario, they can consider heart rate less than 100 with systolic blood pressure less than 100. So there is cutoff and there is no consensus on which is the appropriate. It depends on your outcome. If you want to include or recruit all the sick patients, you can now have the 100 as the cutoff. So if you want to manage the outcome depend on the need for transfusion, you may choose the cutoff that can be borderline, or the specificity and the sensitivity play a role here. So it can be 90 and it can be 100. The most important is that the heart rate is going the same direction of the systolic blood pressure, either less than 90 or less than 100. Rarely the term relative bradycardia is replaced by the terminology of paradoxical bradycardia. And sometimes they just mention there is absence of the tachycardic response. So some author is using relative bradycardia, paradoxical bradycardia, absence of tachycardic response. These three terminology describe the dissociation between the systolic heart rate and the systolic blood pressure and the heart rate. So relative bradycardia has different definition and implication in the medical and the surgical setting. So in medical setting, it's called it reflects the pulse temperature dissociation. To patient came with fever, you expect that the patient has tachycardia, but in some infectious disease or medical disease, there is dissociation between the pulse and temperature. Fever will be with absence of tachycardia or bradycardia, like typhoid, lymphoma, leptospirosis, and so on. In surgical setting, it's called pulse pressure dissociation, as we mentioned before. The relative bradycardia may indicate imminent shock after traumatic injury or traumatic brain injury associated with torso injury or torso injury without TBI. So in general, there is internal bleeding with relative bradycardia. So relative bradycardia indicates that this patient impending shock and will go to shock if not managed with massive transfusion, vasopressor, and so on. However, in another situation, the relative bradycardia can reflect abnormal neurological response. There is no bleeding here in the torso, in the chest or abdomen, but it could be in the brain only. This will increase the intracerebral pressure, causing Cushing reflex, which indicate serious problem, which is the imminent brain herniation. So Cushing reflex, which is hypertension here, it's not hypo, bradycardia, diminished respiratory effort. So this patient should be diagnosed as Cushing reflex. Why? Because it requires urgent neurosurgical intervention to release this high intracerebral pressure. The incidence of relative bradycardia among overall trauma patients is not too high. It is between 1 to 3% of the overall trauma patient. But if the patient has hypotension, means the blood pressure is less than 100 or 90, according to your definition, if it is, for example, less than 100, the incidence of relative bradycardia is high. It can be 7% and up to 44% in some studies. So again, traumatic brain injury, why it is in this context? Because it can be isolated. And if there is a relative bradycardia, this means this ICB is high. Or TBI, as a part of polytrauma with bleeding, this will cause another the indication for the relative bradycardia. So relative bradycardia in trauma, it depends on is it isolated brain injury or brain injury within polytrauma or polytrauma only without brain injury. In isolated severe TBI, bradycardia is associated with high ICB, brainstem compression, and this high ICB will reduce the cerebral perfusion pressure, and this will worsen the secondary insult in the brain, and it is linked to high mortality and poor functional outcome. Again, relative bradycardia is common in adult trauma patients presenting with hypotension, and it is associated with higher mortality. We have conducted a study in a well-validated national trauma registry in Qatar. This over 10 years. We have looked to 16 of almost 17,000 trauma patients using the on-admission relative bradycardia defined as systolic blood pressure less than 100 with simultaneous heart rate less than 100. We found that the relative bradycardia occurred in about 4% of this patient. And when we compared this with this relative bradycardia and no relative bradycardia, we found the blood transfusion in patients with relative bradycardia is about 42%, compared to only 16% if no relative bradycardia. XLab, exploratory laparotomy, is needed in 16% of patients with relative bradycardia, compared to only 5% if no relative bradycardia. So it will indicate that you need to have intervention. The mortality is also a triple. The mortality in the relative bradycardia group 9% compared to 3%. And in the multivariable analysis, using the other variable like sepsis, ECG, ED, Glasgow scale, the injury severity, cardiac disease, head injury, pelvic injury, abdominal injury, chest injury, gender, age, relative bradycardia, we found that relative bradycardia is an independent predictor of mortality. So bradycardia can be a part of the brain-heart interaction. So there is a close relation between the brain and heart. So this bradycardia can be due to high intracerebral pressure, brainstem injury, autonomic imbalance, a balance between the sympathetic and the parasympathetic drive. So which is a predominant system? If it is the bradycardia, if this parasympathetic dominant, we can see this in some patients or some people who can get easily fainting attack when they see exposed to any stress. This is because the dominant system is parasympathetic. Another cause of this brain-heart interaction or bradycardia can caused by hypothalamic pituitary adrenal axis disruption. And don't forget the massive internal bleeding, which can be associated injury in those patients with this interaction also. And why we should know the relationship between the heart rate and the brain? Because there is a journey between the heart rate until we reach to the cerebral perfusion pressure. How the heart rate affect the cerebral perfusion pressure? And if we slow this one, also this will be less, which is not good for patient, especially the patient with brain injury. So maintaining appropriate cerebral perfusion pressure is critical in maintaining managing the traumatic brain injury patient. So there is some equation which looks boring, but it is very important to know. This will explain how the heart rate end up with brain injury problems during management. So the cerebral perfusion pressure is calculated the difference between the mean arterial pressure and ICP. Okay, so the mean arterial pressure is influenced by the heart rate, stroke volume, and systemic vascular resistance. So now the heart rate starts here to appear. The mean arterial pressure is calculated at the cardiac output multiplied by systemic vascular resistance. The cardiac output is a product of the heart rate and cardiac stroke volume. So any abnormality in the heart rate will affect cardiac output and so on until we reach that affection of the cerebral perfusion pressure. So too slow heart rate will reduce the stroke volume and blood pressure, leading to hypotension and organ malperfusion. What other traumatic causes of bradycardia? There is what's called trigeminal cardiac reflex. It has been shown in patients with brain injury as a result of direct craniofacial trauma. Clinically, this reflex results in a triad of parasympathetic dysrhythmia as bradycardia, hypotension, systemic vasodilatation, decreased cardiac output, and apnea. Temporary disruption of the respiratory rhythm, which is indicating the high ICB and compression of the brainstem. Also, bradycardia can be happening in spinal cord injury. A study from Qatar also showed that there was 138 patients who were admitted to the intensive care with high spinal cord injury. 33% of them had prolonged bradycardia, it can last for a week or more. This high spinal cord injury was defined as injury in the spinal cord above the fourth dorsal vertebrae. Because at this level, it cut the sympathetic outflow and maintaining the parasympathetic flow will cause the parasympathetic dominance, and this will be reflected as a cardiac conduction abnormalities like bradycardia, heart block, or even asystole. You should know that the higher the level of spinal cord injury, the more profound the cardiovascular involvement. So this is to summarize the bradycardia issue. There is true bradycardia, less than 60. Pressure is not, it can be normal, high, low, no blood loss, no fluid loss. This is the true bradycardia. Or relative bradycardia, as we mentioned, was using cutoff 90 for the heart rate, 90 for the systolic blood pressure. This relative bradycardia can be medical or traumatic injury. In the medical condition, we mentioned the pulse temperature dissociation. In traumatic injury, it can be isolated, traumatic brain injury, or non-traumatic brain injury. The non-traumatic brain injury can be non-hemorrhagic as a vagal response to pain and emotion, or hemorrhagic that, as we said, in 20%, if there is 20% blood loss in 1/3 of the people, will cause bradycardia because this will lead to incomplete left ventricular filling, ventricular vagal fiber stimulation, and the bradycardia. Isolated TBI, as we mentioned from the ICP. So in conclusion, relative bradycardia is under-recognized and under-appreciated emergency setting. Patients should approach, physicians should approach patient presenting with relative bradycardia with high index of suspicion and timely management. Bradycardia into traumatic brain injury reflect a spectrum of underlying mechanism with distinct clinical implication, either a physiological response or due to pathology in the brain. Relative bradycardia and true bradycardia arise from different physiological pathways, including autonomic dysregulation, brainstem involvement, massive bleeding, and should therefore not be interpreted the same or uniformly across trauma context. A comprehensive understanding of bradycardia within the broader neurocardiac framework may contribute to more precise risk stratification, and it will be reflected translated to improved patient outcome. Bradycardia, especially the relative bradycardia, would be valuable if integrated in the ATLS guideline. ATLS guideline for managing trauma is not including relative bradycardia, and it should be included because relative bradycardia has red flag sign of serious underlying condition. We need to unify the definition of relative bradycardia, of course, and we need to standardize the reporting of confounder that can cause bradycardia rather than we mentioned before, like drugs, beta blockers, calcium channel blockers, electrolytes, disturbance, acidosis, hypothermia. And it is the reference to our paper that published this month. Thank you.
Thank you. Thank you very much, Dr. Almania. Are there any questions? Dr. Almania, thank you very much for this fantastic presentation. I was wondering, it's a very bad sign when you have bradycardia. Is it parasympathetic dominance, or is sympathetic system giving up as an imminent sign of death?
Dr. Prabat, I'm sorry.
He's not
Doctor, yeah, he's not in here now. This video is from the recording one. He's not online. He's an offline now. Sorry for this misinterpretations. But you know, we can get. Thank you very much. But we can get your information about the contributions about trauma sessions, also for these last sessions, bradycardia. What does it mean in trauma patients? You can get we can get your contributions. Is there any aspects or questions from the audience? Yeah. Dr. Khalid? Yeah. Maybe we can. maybe we can get the microphone now. Yeah. Yeah.
The classic neurologic, presentation from the spinal cord injury above the C6, it will give you. So it was missing from the, presentation that it need to be considered in trauma. Sometimes it is the, the cause of trauma unless proven otherwise. So the patient will come classically bradycardic and hypotensive. So I did not see that he mentioned the trauma above the C6. He did, yeah. I did not see it, yeah.
128 high spinal cord injuries, and about 33% of them they has bradycardia. He mentioned it.
Yeah, he mentioned a little bit of it. Yeah. Okay, I think.
One comment, if you don't mind. Relative bradycardia, it can delay the cognition of shock. So, generalizing this, I think it's not good, especially with our teaching for ATLS, that we cannot say it is a relative bradycardia and the patient is not in shock. So I think we need to be very cautious with this, and we need to combine it with other modalities. For example, the ultrasound, the IVC filling, and so it is. I think it is too early to say and generalize it as part of the ATLS protocol. And those 20% of trauma patients where they have the relative bradycardia, I think it's not only related to hypovolemia. It is a combination of vagal stimulation as well as the hypovolemia. So we need to be very cautious from that perspective, I think.
Thank you, Dr. And maybe we can also add that, the medication is very important for these relative bradycardia patients, because in these, especially advanced stage trauma patients who taking medication with negative chronotropic effects, especially such as beta blockers or calcium channel blockers, so it will decrease the heart rate, but without attending to the heart rate. Maybe the medication also important for this relative bradycardia. You should take care for this, especially for the older patients. And also, is there any contribution, Andreas?
We can wrap up, I think. Thank you very much for
Thank you very much.
presentation and also Dr. Isa. Thank you.
Thank you.
Thank you.
Very much.
Thank you very much.
And we're closing session. Thank you very much.
face is turning gray.